Today we're going to perform a nasogastric intubation. As you can see, I have your patient prepped with the chucks in case he should have a large emesis, an emesis basin, and a box of Kleenex. This is what we call a Salem sump tubing. Salem sump is because it has the white connector is for the connecting to the suction and the blue is for the air. This is called an anti-reflux valve. Anti-reflux valve is just what it states. It keeps the reflux from coming back up the tube. The first thing I need to do is I need to assess my patient after I explain what I'm doing, assess my patient's nostrils to see which side is the better one. Make sure that he hasn't had any nasal polyps on one side or the other, there's no septal deviations. After I have assessed which side I'm going to use, I am going to measure to see how far this tube needs to go down. And to measure, you would go from the tip of the nose to the tip of the earlobe, from the earlobe down to the xiphoid process. Once you get to that mark, you're going to have a tape over here on your bed that you're going to mark, bedside table here, excuse me, that you're going to mark how far that tube is going to go down. So this is how far the tube is going to go down into to reach his stomach. It is an estimate. We will do some checks on it. I will have a glass of water available because he will need to drink some water during my insertion of the tube so that the tube can easily go down. The first thing I want to do is maybe coil the tube just a little bit on the end. You want that little rounded piece here because that is how the normal nasal passageway goes. I'm going to put in a little bit of lubrication in the first 4 inches of this. And then I'm going to insert it. I'm only going to insert it 3 to 4 inches till he starts to gag. I'm going to have him look straight forward as I insert the tube. And as soon as he starts to gag, or hopefully before he starts to gag, you're only going to go down 3 to 4 inches. I'm going to hold it there and give him a break. Then if you have an assistant, you would have them to hold the glass of water so that the patient now can start swallowing. On these mannequins, I will not be able to insert it all the way down to where it's supposed to, but on a real person you would. Now I'm going to ask him to swallow, 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 always holding onto the tube as you push the tube in. Swallow, swallow, and I can't get it any farther. So now I am going to hold on to the tube. Do not let go of the tube. I'm going to take a piece of tape, and I have this tape divided with a tear down the middle. This is going to be going on the bridge of his nose, and around one side is going to go around the tube. That's going to temporarily hold it in place as I do my checks. My checks are to take a cath tip syringe, 60 cc syringe. I am going to unclamp this, and I'm going to put 5 to 10 cc's of air down into the tube. I'm going to listen with my stethoscope over the fundus of the stomach, just to the left-hand side of the xiphoid process. As I push the fluid in, push the air in, I should hear a swoosh. If I don't hear a swoosh, I can also take and aspirate a little bit of stomach contents here. Once I get my stomach contents, I'm going to clamp the catheter again or connect the end here so that nothing comes out. Come over here to my little sticks here so that I can determine what the pH of that is. So I'm going to put some on my stick here, and I'm going to look to see what the pH is. If the pH is below 4, 0 to 4, you are in the stomach, which is where you want to be. Then you can take and wrap and secure the rest of the tape around. If you had trouble getting the NG tube down and your patient was gagging a lot, you might want to check the back of the throat to see if there is any curling around in the back of the throat, because sometimes it gets stuck up in there. I am then going to hook it up to the suction. I'm going to connect it to the suction, start the pump. At this point, I'm going to take a clean syringe and I'm going to put 5 to 10 cc's of water. What happens when you turn on the suction is this tube will stick to the side of the stomach wall. What you need to do is you need to get that off of that stomach wall. That's why on a Salem sump tubing, you would take 5 to 10 cc's of air and put it in the blue tubing. That is the only time you put air into the blue tubing. And then you will put your blue-to-blue anti-reflux valve on it again. I'm going to take my other piece of tape and I'm going to just put a little tape here and give him some flexibility here and tape this to, or excuse me, pin this to his gown. You can put a pin right through this tape now and pin it here so that he can still freely move his head. Now you come in and it is a few minutes later and you notice that nothing is coming back in the tube. His stomach is distended, so you know that it's probably blocked somewhere. You have to try to do your checks again. So you're going to shut off your suction, take your 5 to 10 cc's of air, disconnect your suction, and try to push the air in while you are listening with your stethoscope to the fundus of the stomach. No air is going in, so you know it's blocked. As you try to pull it back out, you can't get any secretions out. What you will need to do then is go ahead and fill your syringe with 30 cc's of water. It seems to be just regular tap water, seems to be a standard procedure. Go ahead and grab your syringe and your tubing in one hand and pump it. Pumping action will hopefully be able to get that clog through. Once it goes through, whoosh, it went through. You can disconnect, reconnect it up to your tubing, turn on your suction pump. Then you need to come back with a new syringe. What do you need to do? 5 to 10 cc's of air goes into the blue tubing to get it away from the stomach wall. Whoosh, it's away from the stomach wall. To discontinue this, you come back in, a couple of days later, and the doctor says, take it out. He doesn't need the NG anymore. The first thing I want to do is come in and I want to assess bowel sounds. I want to make sure that I am hearing bowel sounds at all 4 quadrants so that I know his bowels are active. I'm going to have my water available because I do need to irrigate it. In this tube is lots of dark bile. The first thing I want to do is, again, check for placement. I'm going to take 5 to 10 cc's of air. I'm going to check for placement with my stethoscope on the fundus, insert that air. No, air went in fine. I'm going to try to aspirate contents, come over here with my pH strip, measure if it's between 0 and 4. It's good. Then I need to come back, and now I know it's in the right place, so I can put some water in there to irrigate. I'm going to add 20 cc's of water and 20 cc's of air. That's a standard protocol, but please go by your facilities protocol. Hold your syringe in an upward position. So you have 20 cc's of water, 20 cc's of air. Holding it in an upward position, I am going to push the water through, which will clear out all the bile in the tube. Then I am going to push the air through, which clears out all the water. Leave it connected, lay it on the patient's chest. Now you are going to remove the tape, and with a hand-to-hand motion, overhand, please ask the patient to take a deep breath and hold it while you hand over hand remove that tube. That will be removal and the end of this procedure. Do your documentation, your DART documentation, and make sure you do good oral cares.